Level 1 evidence at this time suggests that if you're going to use PRP for osteoarthritis, and let's just call it inflammation within the knee, two things I think you can say about that. The first thing is the literature, I think, pretty well overwhelmingly would say that the correct formulation is to use the non-white blood cell containing PRP, or that's the ones where the neutrophils are taken out. You have a lot of companies, again, what Tom was talking about, so then it's a little confusing. Do you have the lymphocytes in there? Forget all that. It's about the neutrophils, and I think the literature shows that it should be neutrophil depleted. Second thing, if you're going to use it in osteoarthritis, I think we're starting to see a difference that there's a certain group of people that have inflammation as part of their arthritis. The boggy, a little bit of reactive effusions after exercise, and it's seeming that PRP works for inflammation. That's what it does biologically. So then it's having a tendency to have a better effect in those patients with osteoarthritis with an inflammatory component. So if you have just that bone dry osteoarthritis, I don't know how well this PRP would work, because all it typically does is decrease inflammation.
Okay. So you said there's little evidence for usage of PRP for rotator cuff repair, cartilage regeneration. Would you agree?
Would I agree?
Yeah.
Yeah. Well, rotator cuff repair, there's one study by Hernigo, and it's a good study and shows that it works. I just think we need other studies, and there's multiple centers now that are studying this. I do agree that there's no evidence for cartilage regeneration.
Okay. And then I'm confused here. Which PRP system should I use? You said flexible or multiple systems. What's the difference?
Yeah, well, the difference is that they all make different types of PRP, and I think that's what Tom was explaining on that video. And the bottom line is that if we go back to those slides, one type of PRP doesn't work for everything. For instance, the best literature now suggests that including the white blood cells or the neutrophils in the type of PRP is best for tendinopathy. But again, as we just said, if you are treating a patient with arthritis and inflammation, the best evidence is that you want the depleted white cell. So you can't necessarily just have one machine, because you need multiple types of PRP to treat your patient. So either you'd have to have multiple machines there, a white blood cell producing PRP and a non, at least those two, or another one that's variable, where you can make multiple formulations, and there's at least a couple of manufacturers that can allow that.
Okay. So if you look at the meta-analyses PRP for knee OA, it's viable for knee OA, has potential to provide symptomatic relief in this study up to 12 months. 10 randomized controlled trials with over 1,000 patients, follow-up 6 to 12 months. There was some evidence that PRP gave improved relief in the DIE study. Here's a level 1 study just published this last month in AJSM. PRP did not provide an overall superior clinical improvement compared with hyaluronic acid in terms of either symptomatic, functional improvement at different follow-up times or effect duration in this study of 167 patients. So this was just published in Journal of Arthroscopy in January of this year. This is a little contradictory to the Martino article, except the VS in this study was not high molecular weight. Jason, what do you make of all this? I mean, is it something that's pretty effective in your practice to use more visco, to use more PRP? How do you handle a patient like this?
Yeah, well, the first is sledging through the literature on this, which is confusing, because PRP, again, is not PRP. So each of these articles use a different type of PRP. So then summarizing everything in a whole, you cannot just go from one randomized trial and read it and get the answer to the PRP story. So that's the first thing. Second of all, I would use viscosupplementation in a patient with arthritis if they did not have that inflammatory component. But if they had an inflammatory component, then for me in my personal practice, I would use the non-white blood cell containing PRP, and that's kind of the dichotomy. And I think that's the reason that the literature is so confusing, because they have these big studies and they include patients with inflammation in their knee and without. So it's hard to tell the difference and to tease it out.